Good afternoon. Guess what time it is? Straight up 4 o'clock in the mountain times, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast. And it is time for Fertility with Fink and Friends. I am Dr. Randy Fink, and I'm the clinical director of IVF services here at CNY Fertility in Colorado Springs, also the medical director at the Miami Center of Excellence and CNY Fertility at the Miami Center of Excellence. And it's great to see everybody here this afternoon. Looks like Grace Hanna was the first to join on this Instagram feed. We've got CNY's feed right here. And hello, Miss Amber Vince. Thank you for the text you just sent me. And it looks like Mrs. I don't know if I'm going to say it right. Shout, Choute. She is the first one to be here. I'm going to send her a special wave. Thanks for being with me this afternoon. It's Tuesday. I am Fink. You are Friends. And this is Fertility with Fink and Friends, which we do every week about this time. Not only about this time, in fact, at this time. Hi, Allie. Great to see you. Nice to see everybody here. How's your week been? Oh, it's Tuesday. It's a real pretty day outside. Surprisingly, it's not raining here in Colorado Springs, but seems to be, it's been actually a little cooler than usual. Well, it's actually not today. I think it got hot again, but 88 degrees outside here in Colorado. And hi to Vivian over here on the Facebook side. We've got Facebook and YouTube as well as also in LinkedIn joining us over here. Nice to see everybody today. You know, there's always fun things that we can talk about. There's always frustrating things we can talk about. So, you know, kind of where do we start and what do we want to talk about? Well, I'm going to try to get to all your questions today if we can do that. I think that would be fabulous. But something that's been on my mind that I really wanted to be able to share and to bring up with everybody here, and that has to do with kind of the expectations as it comes to fertility treatment, expectations. And how do we manage expectations? How do we really look at what we're doing and feel confident that what we're doing is hi, Alexis, and see how do we really feel confident that what we're doing and that people are doing the right thing for us? Because things don't work every time. I think it's a great idea, right? And science has really done an awful lot for us. These assisted reproductive technologies, we become very fixated on this desire to have a baby. And that's really what we're talking about here. We're talking about in the fertility world. Of course, we will talk about gynecology and women's health and whatever you'd like to talk about. But principally here at CNY Fertility, we do infertility and predominantly IVF. I think we invest a lot of ourselves emotionally and certainly financially into this desire to be pregnant. And we become so captivated by this desire, by just that need to want to be able to see. No sound on Facebook. Is that true? I don't know what to make of that. Can you hear me over there? Because not sure we're going to be able to change that too much. Hope you can hear Facebook. I'm just going to say, can you hear? I have such a problem with audio on these lives. I just don't know what to do about it anymore. Oh, well, Rin says you can be here. Okay, so somebody can hear me. So good. Thank you. I appreciate that. Oh, but Sharika says no. Oh, Ren says I can hear me. Sound is good on my end. Okay, so we're just going to go for this here, and hopefully everybody can hear. We're talking about managing expectations. Science has really come a long way, and there's a lot that we can do to get people pregnant. IVF is really an amazing kind of technology. When I go into the embryology lab and I see them working with embryos and fertilizing eggs, taking one individual sperm and placing it inside a human egg and creating an embryo, literally creating life with that, I think it's really fascinating and it's utterly amazing. but we want so much for it to work for so many different reasons. There's a myriad of these emotional reasons why both women and men seek to have a baby. It's a definition really of who we are. It is how we define ourselves as a species, our ability to procreate. I keep having internet problems over here. Boy, nothing's ever easy today. So let's see if we try a little something here on this side, if that makes it easier. Hopefully that'll quit popping out. When things don't work is when it becomes very frustrating, especially after a huge financial investment, after a huge emotional investment. And what do we do then? One of the things that I honestly commonly hear from folks is the word I'm devastated. We did a transfer and it didn't work, and we are absolutely devastated. And I would say I certainly and completely understand what that's like, because of such an investment of hope and faith in something that you just can't be certain about. The thing that I use to manage my own expectations over the IVF process is that it is a numbers game. It is about, you can't expect, for instance, to go to Las Vegas and to sit down at the blackjack table or to go up to a slot machine, and that you're going to win every time. As much as we may want to, and as much as there may be pretty pictures and the sound of bells going off and everything that tells us, wow, people are winning here. Look at all these people having a good time. And they really make, in Vegas, they're professionals at sort of making you feel like, yes, you're going to win, because they want you to keep putting your quarters into that machine. Well, what happens with us is that every time is not necessarily going to get you the outcome that we want. So when we do IVF, we are able to get some information, right? We're able to use a cocktail of medications in order to be able to see how your body is going to respond. And your body does respond. And when it happens, we get not only some eggs from you, but we get information. We are able to make adjustments and tinker with things if we need to, in order to perhaps be able to do better next time. Every time a sperm is placed within an egg, we are able to get information. Every time we give you some medication and monitor how thick your lining gets, monitor what your estrogen or your progesterone level might be, and place an embryo back, we get more information. Well, when we have a euploid or a tested embryo, that's our highest probability of success, right? That gives us about a 60% chance of succeeding with any individual embryo. When we have a blastocyst that's untested, we say that gives us about a 30% chance of succeeding with any given embryo. And when we have a day 3 embryo, we generally would quote that at about a 15% or so probability for any given embryo. Now, these numbers will change, obviously, depending upon your age, the age at which we get those eggs from you. And so there is made a big difference on that. But so every one transfer does not necessarily mean that it will result in a pregnancy. As much as I would like to tell you that, yes, oh, sure, it probably will. Anybody who tells you that is not telling you the truth. And I think that's an important realization. You and I both know people who have gone into the IVF process or have done, say, for instance, an IUI, an insemination, and they got pregnant the very first time. And when that happens, it's a wonderful thing. It's great. We're a hero. You are perfect, and life is just good, and everything is wonderful. But I have to tell you, those things are the exception rather than the rule, because we generally tell you it takes 2 euploid embryos to get you a pregnancy. It takes 4 untested blastocysts to get a pregnancy, and it may even take up to 8 day 3 embryos to get a pregnancy. So when one doesn't work, I would recommend, as easy as it is for me to say this, to say, well, okay, well, now we've learned something. Maybe we've come a half a step closer to getting to where we want to be. I don't like saying a failed transfer. I would say it was an unsuccessful transfer because it didn't result in a pregnancy. But a failure, no, I don't think so. I think we learn something every time we do this. And so every time we come back to the table to try again, it means that we're one step closer to getting there. I would continue to look at the process with faith, with hope, and with the understanding that the science isn't perfect, but it's pretty damn good. And we know what we're doing here. We know what we're doing, and you're in the right place to get the help. So faith, hope, and honestly, just the kind of encouragement that comes from being with a community of people who have been through the same process that you have. Let us do what we know how to do. And it'll take a little bit of luck with it, and we'll keep our fingers crossed. So that's my words of the day, words of wisdom. And it only took me 13 minutes to vomit that out. So that said, and gosh, I'm having all kinds of technical issues here, but so sorry to be stumbling around a little bit there. Amber says, so much this. I've had a long journey, but support and faith have been one of the main reasons that I've been able to keep going. And, support and faith are, it is just, it is part and parcel to the entire process. And God, I certainly hope that it's an easy journey for you. But even if it's a very difficult journey, please know you are not going on that journey alone. All right, well, let's take a look at some Facebook questions here. Oh, there's my friend Sally from Trinidad. Nice to see you. Hi, I'm glad to have you here. And let's see, I've got a question it looks like from Angela on the Facebook side. And Angela says, I only have my right tube and per the HSG, I am blocked. I had one reversal and now my doctor is retired. So if you have, it sounds like, Angela, what you're saying is that you have only one tube and it is blocked. That often happens. Why do tubes get blocked? Tubes can get blocked as a result of infections that most of the time you don't even know that you have. Tubes can also get blocked because we block them. And it sounds like you had, since you mentioned you had a reversal there, that means you had a tubal ligation. So sometimes we are absolutely certain that we don't want to have another baby. And then that certainty falls by the wayside, and then we really wish we hadn't tied our tubes. And then you can either try to reverse those or you go right to IVF. So what do you do in that situation, Angela? That's what IVF is for. In vitro fertilization is where we rev up your ovaries in order to get you to produce as many eggs as we can get, which we then retrieve from your ovaries under a little sedation done in our office. Eggs go to the laboratory. We have partner sperm. One sperm goes into each egg, and that creates an embryo. And then those embryos we can do some different things with. We can place an embryo back inside of you, the same cycle that you had your stimulation. That's called a fresh transfer. We can freeze the embryos, let your body recover, and thaw an embryo later on and place that embryo inside. That's called a frozen embryo transfer. Frozen embryo transfers are generally a little bit more successful than fresh transfers, but fresh transfers are included in the price for IVF here at CNY. So if you can do a fresh, you do a fresh. But that's what you do when you don't have tubes that work, or if your tubes were removed. IVF outcomes are generally better in most cases than a tubal reversal. So that's what we think about, Angela. And so it doesn't matter if your doc is retired there because we have the technology. Looks like to me, I can't see it from here. Miss Reed starts with a T, but I'm a little far away from it, and I think I've got a smudge on my glasses here, so sorry about that. Do saline sonogram procedures happen on your period? and start your IVF stem the same day? No, the answer is no. So when in general, well, I mean, put it this way, if you're planning to do a fresh transfer, then we don't want anything touching that endometrium. The endometrium is the uterine lining. We don't want anything going in there, anything touching it, except for the embryo when that time comes. Now, is it possible for you to do a saline sonogram during your stimulation? The answer is yes, you can, as long as you're not planning to do a fresh transfer. So usually what we do is the HSG, or rather the saline sonogram, which we're talking about here, is done usually during the diagnostic month in most cases. And at the CNY facilities in Syracuse and in Colorado Springs and in Sarasota, we will do a hysteroscopy, which is where we look inside with a camera at the same time as an egg retrieval. They don't do that in Albany, and I'm frankly not so sure about whether they'll do that in Buffalo. But that's the other way that we can look inside the cavity. So hopefully that answers your question. Sally in Trinidad is still waiting on Sarasota. Who is the doctor in Sarasota to do the egg retrievals? That's Dr. James Condrup. Jim Condrup, great doctor, very, very nice man. He is available for your consultations as well through CNY, so feel free to give us a call. I am told that potentially it's any time now. Originally, it was supposed to be July. Due to some permitting things and some technical equipment going in, got pushed off to August. Now it may be September. When it happens, it's going to happen, and it's going to happen very soon. God willing, I know Dr. Condrup is certainly anxious to get started. Right now, Sarasota is a monitoring center, but soon enough, we'll be full service IVF. So my friend Shanna says, you mentioned last time that after Orilissa, that you would probably need to do a medicated or a modified natural transfer. How do I know which of those to do after suppression? So you ask a good question. And basically the question is about endometriosis. So when we determine that endometriosis is in play, and endometriosis is, of course, where that lining of the uterus that normally sloughs out when it's time for a period, instead of coming out the door, works its way up inside and implants inside the abdominal cavity. And then it serves to stand in the way of the way the brain is talking to the uterus. That can result in failed embryo transfers. When we do a laparoscopy and find endometriosis, or when we do a non-invasive test called a receptiva to diagnose endometriosis, we then recommend that you use suppressive therapy for 60 days. That suppression comes in the form of medication. It's either Lupron. So Lupron was the original medication that was used to treat endometriosis. And basically what it does is that it completely shuts down all the hormones. And so I will tell you, just as anyone who has used Lupron for a prolonged period, doesn't feel great. It doesn't feel great to have all of your hormones turned off. So they came up with some other medications. Orilissa is one medication. Myfembree is another medication. And these are oral pills that you can take that will suppress that endometriosis. 60 days is what's recommended. And after that 60 days of suppression, you can go right into the next transfer cycle. And in theory, your odds of success with that next transfer cycle should be significantly higher. So that's why we treat endometriosis in general, and that's one of the reasons that we even test for it specifically after some unsuccessful transfers. That's one of the things that we can learn. So what do you do? Well, as you may know, I'm a big fan of the natural cycle as opposed to a medicated cycle for an embryo transfer. And I think you probably know what that means if somebody wants to add. If you're not sure, I've talked about it so many times here, but happy to go over it again. Well, what the heck? So with a medicated cycle, we are giving you all the medication. We're giving you all the hormones. We are taking over on behalf of your body and putting the hormones in to do exactly what we want for them to do in order for you to achieve a pregnancy. Well, when we do that, there's some benefits. What's the benefit? We can control every variable. There's nothing that's sort of left to chance. We're able to test all those levels and follow everything. These medicated cycles have been around since IVF was invented. So 40 years now they've done these medicated cycles. So there is a huge volume of literature telling us that medicated cycles work. We know how to do that. Well, in the last couple of years, there's been some increased interest in the natural cycle. And in a natural cycle, we're letting your own body's hormones contribute to the program. We still monitor. So when we say natural, some people are like, does that mean that you just let it do its thing and hope that I get pregnant? No, we monitor everything. We still look at all the hormone levels. We look at your lining. But basically what we're doing is that if you have a normal period, then we are able to if we have a normal period, then if you have a normal period, then basically we let the follicle develop. That follicle secretes estrogen. That estrogen is where your estrogen comes from, and that is how you thicken up your lining on your own. So rather than having to use a bunch of extra estrogen, your body's doing it yourself. Oh, what a brilliant thing that body is, right? Then when we see that that follicle is of sufficient size, we can trigger your ovulation, which tells the ovary to release the egg. And when the egg gets released, then your estrogen making factory becomes a progesterone making factory. And so you're getting your own progesterone. So rather than having to do the progesterone in oil shot, you only have to do some vaginal progesterone. Oh, that's a huge benefit. Well, the data shows us that a natural cycle is at least as effective as a medicated cycle. And in fact, the data also shows, some data shows that a natural cycle may even be better, more successful than a medicated cycle. So I love the natural cycles, but it still depends on your body to have to cooperate and do kind of what it's supposed to do. Natural cycles also have a lower miscarriage rate and certainly have a lower risk of certain types of complications during the pregnancy, which specifically means blood pressure type complications. A modified natural cycle is really for folks who are not releasing an egg on their own. So if you have polycystic ovarian syndrome, for instance, that's a good reason to do a modified natural. With the modification that we give you ovulation induction. So we'll give you some letrozole, for instance, in order to make sure that your ovary to release the egg. If you release an egg on your own, if you ovulate, if you have a period every month, I am not an advocate of using letrozole when you release your own egg for an embryo transfer. But if you don't release an egg, letrozole is brilliant. It'll get you to release an egg. So Shanna is asking, well, after stopping that suppressive medication, should I do a medicated cycle or should I do a modified natural? Well, you're on suppression, right? So it may not be that your body jumps right back into doing what it's supposed to do immediately as expected in the very next month. So for that reason, I would recommend the modified natural as opposed to a natural. And in most cases, I'm going to tell you a modified natural is my preference over a medicated cycle. So to answer your question, it's still a matter of choice. You know, it's still something that you can do whatever you feel most comfortable with, but all other things being equal, I would say the modified natural, Shanna, is probably the best way to go. Hi, Meek01. You're new and looking to go to one of our clinics. Well, we are excited to see you. And Shantur, I think that says Shantur. No, Shantur. Well, hi from Calgary, one of my favorite places. I just had some friends who were in Calgary last week, and what a beautiful place to be. All right, let's see. Looks like Boo says chances of pregnancy, blocked fallopian tubes on the right, one removed, and left blocked all the way, just turned 30. Okay, so, and hello to Brandis, who just joined or joined a little while ago that I'm just seeing. Hi. Okay. Wonder how my eggs and embryo will be at 30 years old. So, to answer that question there, Boo, if you have blocked tubes, then IVF is really the way that you want to go because we don't need the tubes. And in fact, if the tubes aren't working, you're not going to get pregnant doing it the natural way because sperm swim inside, meet up with the egg in the fallopian tube that's been released from the ovary, gets taken up into the tube. Sperm and egg meet in the tube, and that creates your embryo, which then swims its way down. It doesn't swim, it actually gets moved its way down into the uterine cavity where it implants. So if the tubes are blocked, there is no highway for sperm to be able to meet egg. So what are you going to do? We offer you that same opportunity of sperm meeting egg in the laboratory. And at 30 years old, your odds of success with IVF are going to be really very, very high in most situations. So that sounds like a good plan to me. It's me, Mrs. C. Do estradiol patches cause a cycle to start early? Well, that's a kind of a little bit of a trick question there because let's say that you're using estrogen patches and in IVF, I will be honest with you. So my treatment for menopause, I think pellets are really the best way to go to treat hormones. But treating through the skin with a cream or a patch is generally what I consider to be a good thing. I don't like pills in treating the menopause, but for fertility, I like pills much better than patches because we can really measure what's being absorbed into your system, and what you're taking more directly correlates with what we're giving you. But if you're using a patch, and let's say you have that patch on for a week or 10 days during your cycle, and then you peel that patch off, what's going to happen to your hormone level? Your hormone level is here, and then you take the patch off and you stop it, the hormone level drops. And when the hormone level drops, that's what triggers us to have a period. So that's called a hormone withdrawal bleed. And so kind of like I say, it's a trick question there, Mrs. C. Does it cause a cycle to start early? Well, if you take the patch off too early, or if that hormone level drops, yes, it will make you start bleeding. All right. I hope everybody's having a good afternoon here. Sure is nice to see so many friendly faces. Gosh, especially on the CNY Instagram side here. We've got a lot of folks on my Instagram, not as many people today. So let's see what we can do here. We'll answer some questions. Escobar La Chula 22. Hi, Dr. Fink. Hi. Do we still take PCP prescribed metformin? If so, also, how to increase IVF success? Do you prefer frozen embryos over fresh? Okay, so let's talk a little bit about metformin. So metformin, as you may know, is a medication that's used to treat people with diabetes. So your primary care prescribed you metformin for some reason, probably having something to do with blood sugar. We in the fertility world, will use metformin also to treat polycystic ovarian syndrome. So it's helpful to get people ovulating on their own again. But in the IVF world, it has a very strong effect on egg quality. So it is one of the priming mechanisms that I typically will prescribe in folks with egg quality issues. Metformin can really help with that. Furthermore, metformin can decrease the risk of miscarriage and can also decrease the risk of certain pregnancy complications, specifically things like gestational diabetes. So I would have to say that metformin is a good idea. So if your primary prescribed it for you, I think it is likely only going to help you with IVF. So strongly recommended. Do I prefer frozen embryos over fresh? Well, I'll tell you, if the world was a perfect place, I would think that we would probably always be doing frozen embryo transfers. Why is that? Well, even in the best case scenario, your body has been in egg making mode. And so you go from egg making mode to doing a fresh transfer. They may not be consistent, egg making mode and being pregnant, pregnancy mode. It may be a little harder to get there. So our frozen transfers typically have a little bit higher of a success rate, kind of across the board. Now, everybody is different, and fresh embryo transfers work. People get pregnant from them every single day. So please don't hear me to say that a fresh transfer doesn't work, because it absolutely can. But if you look at the overall success rates, they're a little bit higher with a frozen embryo transfer. And that's the reason why, because the body has been in egg making mode. Now, I will tell you that there are some situations where, especially because, at CNY, the fresh transfer is included in the cost. And there are some situations where folks are really hell-bent on wanting to do a fresh transfer for that reason. But something happens with their hormones where when we look at their levels, we find, you know what? It's just, it's not a great idea. It's probably not going to work. There are some numbers that show us hormonally that specifically it probably will not work. If your progesterone at a fresh transfer is above about a 1.5, please don't do a fresh transfer, because odds are you're going to be spending an embryo that is not going to get you pregnant. Can it get you pregnant? Well, I suppose it can. I'm sure there are people out there who will say, well, my progesterone was 1.8 and I got pregnant with it. Absolutely. Stranger things have happened. But as a rule, it's probably not the best idea, because your body's telling you, listen, we've been making eggs here. Just get a period, slough that lining out, reboot the system, and you'll have a much higher chance of getting pregnant. All right, Kendra is on the Facebook side over there. If somebody has PCOS without consistent cycles, would you still recommend a natural cycle? And Kendra, I presume you're talking about for a frozen embryo transfer. If you do not have consistent cycles, then do not try to do a natural cycle, FET, frozen embryo transfer. There's no reason to sit around waiting for months to get a period so that you can start the process. We can very easily make your ovary release an egg, and that's what the modified natural FET is for. So hopefully that can help you. Sally is asking, can a patient ask to transfer 3 embryos? There are circumstances where 3 embryos is within the guidelines. So if you are, let's say, 42 years old and you have day 3 embryos, transferring 3, sometimes even 4, potentially even 5 embryos may be appropriate, because the thinking is that what's the likelihood that they're all going to stick? Certainly the older we are, the less likely those embryos are to be normal. So transferring more of them at once has some rationale to it, because we're able to get more in, we may increase the probability of a positive pregnancy test. If you are 27 years old and you come in asking to transfer 3 embryos, odds are we are going to tell you no, because that's just, at 27, your odds are fairly high that you're going to get pregnant, and we absolutely do not want you to have triplets. That I would consider to be potentially catastrophic. So that we do not want to be. Jen asks for any recommendations over 40, just turned 45, and all the embryos keep coming back aneuploid. Well, Jen, that too is a very frustrating problem, because you're making embryos, they're just not normal embryos. Part of that is the biology of aging, or maturing. That's the word I prefer to use, although many would argue that I am getting less mature as I age, but you understand what I'm talking about. The issue there is that the DNA, the genetic material that's in those eggs, becomes less stable over time, right? So we're just more likely to produce embryos that are not normal. And at 45, it truly is an uphill battle. The odds of a successful pregnancy through IVF at 45 are unfortunately very, very low. But what can we do about that? Well, the things that I like to do is to prime before your retrievals. And that would be to be on the correct supplements that can help your egg quality. That would be to be on some omnitrope, which is human growth hormone. That would be to be on metformin, which can help with egg quality. Those things really can and do make a difference. Sometimes we can do some things with the ratio of your FSH to LH, especially if you're using the Menopur medication, that may have an effect on egg quality as well. So there can be, but we do get somewhat limited there, my friend, because there's only so much that we can do when fighting this problem of nature. What else we got going on here? My friend Alexis there is asking, is it true that a short person like me can't do natural birth in the future? My friends were telling me. You know what? I'm not sure that those people are your friends, Alexis, to be honest with you. So, before I came here to Colorado Springs, I practiced general obstetrics and gynecology I've been in medical practice going on between 25 and 30 years. But I, as an obstetrician delivering babies, do you know how many short people I delivered? What does that really say about our culture, about our genetics? Now, forget about culture. What does that say about genetics if short people can't deliver their babies? Well, does everybody have access to a C-section? Well, in this day and age in the United States, probably most people have some kind of access to a C-section if they need it. But what about, in other places where there may not be hospitals? Think about the plains of Africa, where healthcare may be really pretty hard to come by. If you're short in Africa, does that mean that you're going to die in childbirth along with your baby because you're too short? No, I don't think so. There can be a size problem. There is no question. And certainly if you're little and you're having a big baby, there can be what we call cephalopelvic disproportion. Cephalo means the head, the cephalic, the head, and the pelvis can be out of proportion. The head can be too big for the pelvic bones. But remember, the female body is meant to have babies. Absolutely, positively, there can be babies that are too big to come out vaginally. So don't hear me wrong there. Don't fight with your obstetrician. If they really believe that baby's not coming and you stop dilating, there's a reason for it. And if you say, I refuse to have a C-section in that situation, you're really asking for trouble for your baby, because eventually the baby will become distressed over that. And that distress means that there may be some challenge in getting oxygen to the baby. And what organ do we have in the baby's body that needs that oxygen very desperately? It's the brain. And so that can cause problems. That's the cause of things like cerebral palsy. It's an oxygen related birth injury. So being short does not necessarily mean that you can't deliver vaginally, but it does mean that certainly with a bigger baby, you may be at more risk for having a problem there. But remember what happens. The pelvis expands. The bones, actually all the joints and ligaments tend to start opening up. There's a hormone in the body that's called relaxin. And what do you think that does? It causes those joints to expand precisely so that to maximize the natural probability of a baby being able to come out. So Alexis, don't let your friends guide you the wrong way. People do that a lot. They do that in pregnancy. Have you ever noticed, or maybe if you haven't been pregnant, you probably haven't found out yet, but you will, that once you're pregnant, everyone is an expert, right? Or when you're going through fertility treatment, suddenly the entire internet knows more than you do. And everyone, every relative, every friend of every friend is an expert and wants to give you advice. And much of the time that advice is designed to scare you. It's designed to frighten you. It's designed to show you that they are so much smarter than you. But much of the time their advice is wrong. So take that for what it's worth. Could it be right? Sure, it could be, but your medical provider is the better person to ask there. What else we got going on here this afternoon? Gosh, it's already 41 minutes past the hour. We got about another 21 minutes here, 20 minutes or so. With Fertility with Fink and Friends. Glad to have everybody here. Erica says, I had a clean HSG and it was recommended for me to get a sonohysterogram. My local OB was unable to get the catheter in to complete the sonohysterogram, but he said everything looked clear. Should we try again? So with an HSG, right, which is the dye test, and that's the test that we use to show the shape of the uterus and that the fallopian tubes are open. It is generally considered to be the least favorite test of all the fertility testing because it doesn't feel so good to have it done there. But it's actually helpful. There's a therapeutic value to doing that HSG because it clears out some of the kind of what we'll call the cellular debris that can collect in the tube, and people have an increased chance of getting pregnant in the couple of months after doing an HSG. So it's not a bad thing there. What an HSG doesn't really show us well is the lining of the uterus. Unless you have some big, we'll call it a Goomba inside your uterine cavity, a big filling defect, the HSG may see a big filling defect, but a small filling defect like a polyp, the HSG is likely to miss. So I feel very strongly that anyone who is going to have an embryo, and this is an embryo that you have invested so much heart and soul and spirit and energy and money into making, we want to know that that uterine cavity is just as beautiful as that little embryo that's going to go inside. So if they were able to get some fluid into the cavity there, Erica, to be able to show that the cavity was normal, then I would say you're done. But if the catheter wouldn't go in at all, they were not able to place any fluid inside, a standard pelvic ultrasound looks at the lining of the uterus like a sandwich. We can see the top and bottom layers of the sandwich, but we can't tell what's inside of it. You may have a little something inside that sandwich that's not supposed to be there. So I really do strongly recommend that be evaluated. And if it can't be done with a saline sonogram, then I would recommend a hysteroscopy. And I do feel very strongly about that. Now, again, sometimes if you're doing IVF, we may be able to do that evaluation for you when you're under some anesthesia. So you don't have to feel it. You don't have to deal with it anymore. But my 2 cents worth there. Let's see. Hi from Los Angeles. Hi, Andre. Nice to see you. And Barbara in Miami. Hi, nice to see you as well. Eileen likes my dad jokes. Thank you. Oh, you know what? I didn't even mention anything about my dad jokes. I hope that's not the reason that nobody's really looking at my Instagram today. There's only about 7 people on normally my Instagram has 30, 40 people on it during this broadcast. Today, there's only like 7 or 8. And I hope it's not because my dad jokes made people decide that it wasn't an account they wanted to continue with. Can an iron infusion make your menstrual cycle fluctuate? Typically not. Although things like stress on the body can make the menstrual cycle fluctuate. And depending on how anemic you are, if you're very anemic and you're getting iron infusions, then there may be some stress on your body that is resulting in you having some irregularity, to my dear friend in Los Angeles. So hopefully that helps you there. Rin says, I am supposed to get a saline sonogram. When it was requested, I had a normal cycle. Now my cycle's not so normal. I'm 45. Is there something different I can do other than the saline sonogram? Well, so yes, I would recommend that if yeah, I don't want you to sit around and wait because at 45 the clock's really ticking. We want to try to get you pregnant, get some eggs, or do whatever we're going to do as soon as possible. So I don't want you to wait around for a couple of months to try to get a period so that you can have that saline sonogram. A couple of different things you can do. We can induce a period. We can give you some progesterone, which will make you have a bleed, slough off the lining. And, as long as we're sure that you're not pregnant, then that lining comes out and you can do your saline sonogram on your time. Or you can also consider doing a hysteroscopy, a diagnostic hysteroscopy, which is a camera that goes inside the uterine cavity to take a look. And as I said, we certainly in Colorado and in Syracuse can do that during the time of an egg retrieval. In Sarasota, once they're up and running, they will do that as well. So hopefully that's helpful there. Ren, Michelle is asking, do you recommend Humira and IVIG? I have had 4 failed transfers of 7 embryos from donor eggs since 1 live birth. So, Michelle, that's telling me that there's something else going on there. So, you had embryos made from donor eggs. Those donors are young, healthy people who have, again, high probability of making chromosomally normal embryos. And 7 embryos have gone in and have not resulted in a positive pregnancy test. I start thinking, well, there's I's to dot and T's to cross. I want to make sure your uterine cavity is normal. I want to make sure that you don't have endometriosis. But assuming those things are negative, I also want to make sure that your immune system is not doing something to try to keep you from getting pregnant. IVIG, intravenous immunoglobulin, is kind of the biggest gun immune modulator that we have. The problem is it's damned expensive. And so that's why it's just not realistic that everybody will be able to use it. In your circumstance, if you can, I think it's probably a good idea. Again, without knowing a lot of the rest of the story, I think it's certainly something to consider. Humira is specifically to treat something called tumor necrosis factor alpha, TNF alpha. That's something that we can actually check to see if you have. Humira is also very expensive. And for fertility, it's an outside the manufacturer's recommendation kind of indication. So insurance may not cover it. I would say you can be tested for TNF alpha. And if that's negative, you can skip the Humira. But both of those things are part of our immune level 4 protocol. Once you get to immune level 4, it starts getting very pricey, but we reserve those big guns really for situations kind of like yours. Allie's asking at our consult, you increased my metformin. The next period started much later than normal. Was that because of the dose change? Well, the more metformin you get, the better off you are, particularly in terms of egg quality and with polycystic ovarian syndrome. Ideally, the recommended dose is about 1,500 milligrams or more. So I usually use 750 milligrams, and you take 2 of them at bedtime. Depending on your what we call the volume of distribution, how much body weight you have, sometimes we'll use a little lower dose in you. It's more likely to make you ovulate on time than late. So, Allie, I would think that may have just kind of been one of those things, and I'm not sure that that's directly related to the metformin. Let's see what else we got going on here. Christina says, I just had my saline and everything looks good. Do I need to be looked at for endometriosis as well? The answer there, Christina, is probably not. So a saline sonogram, or the uterine cavity, we really want to know is normal before you start any meaningful treatment. Even if you're doing IUIs or home intercourse, just timed intercourse, we want to know that what's inside that uterine cavity is normal, because I don't want you wasting your time. So the cavity evaluation with the saline sonogram is considered part of the primary or the initial workup. In the case of endometriosis, looking for endometriosis is now something that I would consider more in the situation where things have not been working. And at that point, I would say, then we go looking for it. But no, I don't think that you need to do any kind of endometriosis evaluation up front. The data has showed us that's not particularly helpful. They used to, and I've said this before, it used to be in the fertility world, you would have a laparoscopy scheduled before you ever even met the doctor. Everyone got a laparoscopy, and nowadays we know that that's just not necessary. So hopefully that is helpful to you there. What does it mean when the uterus pushes the catheter out when doing a saline sonogram? Well, so the uterus can push, because remember, what's the uterus do? The job of the uterus is to squeeze the baby out when that time comes. And so it's always doing a little contracting. In fact, in painful menstrual periods, if we measured the strength of those contractions, do you know that some of those cramps you get can be even more painful than the type of contraction you get during active labor, which is unbelievable. And you probably know that because you've had those cramps. But when I actually read that study, I thought, wow, that's some serious cramping. It just means that you probably had a contraction and it pushed the catheter out. And that happens sometimes. We'll even see it at the time of embryo transfer, that we place the catheter in, and while we're waiting for embryology to come to the room, the catheter kind of slides right out. That's because the uterus goes, and it does make that noise. You just have to listen really carefully to hear it, and that's what that means. Just a little contraction there. Can testosterone? This comes from Cheryl on Facebook. Can testosterone help with stage 4 endometriosis? I have not seen testosterone as a specific treatment for endometriosis, but it does make everything feel so much better and may have some suppressive effect at the level of the pituitary gland. However, testosterone is metabolized into estrogen, and estrogen as one of its metabolites, and estrogen feeds endometriosis. So I don't know the answer to that specifically. I haven't seen that as a kind of a standard of care, but I have treated people who have endometriosis with testosterone, because it does make everything else feel so much better. Rachel is asking, our consult is in October. I'll be 36. I have PCOS and 1 block tube. We'll hopefully be able to get to test the embryos. If we were to get 2 high-grade embryos, would we have the option to transfer both? Well, so 2 blastocyst embryos, Rachel, is outside the guidelines of the American Society for Reproductive Medicine, the ASRM. So we don't recommend it. And why is that? Because it can increase the probability of a positive pregnancy test, but it doesn't necessarily increase the chance of a live birth, which means it only increases the chance of pregnancy complications like pregnancy loss. And obviously that's something we would really, really like to avoid. We strongly believe in one healthy baby at a time. Now at CNY, we will not turn you away. We will not refuse to do those 2 embryos. We will still do that for you, even outside of guidelines and against medical advice, as long as you accept that you're doing that on your own terms and that you really are responsible for whatever that outcome is, even though we've told you there's an increased probability that the outcome is not good. They're your embryos, so we'll do that. Now, we won't transfer 3 of them, but we'll transfer 2. Let's see here. Little Lauren tells me, I'm 36 years old with day 3 embryos. At what point would you recommend that I transfer 2 instead of 1 at a time? Well, that is a good question. At 36, the guidelines will tell you that you should, that you're generally going to be doing 1. In reality, if you've had a couple of transfers that have been unsuccessful, then we start thinking, well, doing more than 1 embryo is not unreasonable. So there's not a precise answer to that, little Lauren, but that's generally the thinking. We'd want to see kind of how you do. And my gestalt is 2 transfers that aren't successful, then maybe start thinking about more than 1 embryo. Looks like Ethan Lucas, me and my wife have a consultation on October 25th with Colorado for IVF. I think you've made a wise choice there, my friend. Any thoughts of how to prepare for this and how long would we have to be there during the whole process? We're doing the gender test and the gender testing and the 5-day wait. Okay. All right. So the way that works is if you're traveling to one of our facilities for your treatment, we want you to be here. We want you to get here for sure the day before. The monitoring you can do in your hometown. Wherever that may be. And we have a team whose job it is just to follow that monitoring to get that data for us and to make decisions about your cycle from your local monitoring. We want you to get to your location for retrieval the day before so that you're not stressed out trying to travel on the morning to get there. You have your retrieval the next day. And gosh, there's so many horror stories about airline travel. So, please, for crying out loud, build yourself in enough time so that if that morning flight the day before it gets canceled, that you're still going to be able to get here that day, because there is nothing worse than getting your cycle canceled because you can't be here after all you've spent on medication and on just spirit to get yourself to that point. And the airlines, oh boy, you know how it is these days. So we want you to get here the day before. You do your retrieval the next morning. I like you to plan to stay over that night. Some people want to go home that same day that they do their retrieval. And my opinion is, you know what? Get a hotel room. Go back, take a nap after your retrieval, and just chill out. Go have dinner. Go check out the sites. Make a little sightseeing trip out of it while you're around, and then go home the next day. If you are planning to do PGT testing, you do not have to wait here. In fact, you shouldn't wait here because it's going to take a little while. To do PGT, or pre-implantation genetic testing, those embryos have to grow to the blastocyst stage, which is going to be day 5, day 6, or day 7 after the egg retrieval. So the eggs are retrieved, the eggs are fertilized. The next day is considered day 1. So you need to get to day 5, 6, or 7, whichever embryos make it that far can then be biopsied. That biopsy goes off to the laboratory, and you get a written report in your portal about what was biopsied and what was frozen. It takes probably 10 to 14 days to get those PGT genetic test results back from the embryos. And so then, you will long since have been at home after that, and then you come back to do a frozen embryo transfer. For that, you can really, if you wanted to, get here that morning, but again, ideally, get here the day before so that there's just no stress. You can go home after the embryo transfer. We just tell folks we'd like you to plan to take it easy for 2 days, right? So no, what do I like to say? No bungee jumping, no alligator wrestling, no extreme snowboarding, BMX racing, that kind of thing, skydiving, helicopter skiing. Take it easy for 2 days afterwards. Keep yourself well hydrated, and that's the way. That works. How many, C. Jones says, after how many failed transfers do we recommend additional testing? After 2 to 3 euploids, or generally after 3 untested embryos, I will always be talking to people about testing. In fact, even after 2 unsuccessful untested embryos, we'll certainly be talking to you about possibilities for testing. The most important one there is, I'm going to say, when was your cavity evaluated? Because many people come to us, their cavity was evaluated 2 or 3 years ago, and they just continue to assume everything's normal. My recommendation: once a year, easy enough to do a saline sonogram or a hysteroscopy. One last thing I want to mention here. I hear a lot of questions about anteverted uteruses. Anteverted uterus is a uterus that sits forward. A retroverted uterus is a uterus that sits backward. Just like some people are right-handed and some people are left-handed, some uteruses sit forward, some sit backward. That is not a cause of infertility, nor is it a problem. It's just a variation. So don't blame your uterus for something she can't help. Just like you don't blame your left hand if you write with your right hand. It just is. Looks like we're out of time for the day. Gosh, it's been so nice seeing you. Sorry we got a little rocky start there, but thanks so much to everybody for being with me here at Fertility with Fink and Friends. We'll look forward to seeing you next Tuesday at 4 o'clock p.m. Mountain Time, 6 o'clock on the East Coast. Until then, let me just say infertility is not your novel. It is not your book. It is merely a chapter. And what we're doing is helping you rewrite it. So until next week, God bless you all. Good to see you. Take care. Good night.